I'm Vince Berghella once again. Welcome to AJOG MFM Live with my co-host, I guess, Dr. Mhatre. Take it away. Good
Hi,
morning.
everyone. Thanks for joining. Good morning. I'm Mo Mhatre. I am a maternal fetal medicine specialist at Tufts Medical Center and the director of the MFM Fellowship at Tufts. Really excited to have you guys join us today. It's actually our 1 year of doing this, and we really thank everyone for all of your support and hope you're enjoying these quick learning sessions as we always update everyone on the latest and greatest from AJOG MFM. For those of you who are unfamiliar with our format, we try to select 4 of the top articles from the month that want to highlight that have rigorous study design and also would be applicable to all of our colleagues caring for pregnant patients, both in the office and on the labor floor. And we try to have them be impactful for how you're going to counsel or manage them. We're going to use visual abstracts. We use the author's visual abstracts when they provide them. Otherwise, I create them. But here are the lists of the articles, and feel free, please, to read them in detail on the AJOG MFM website. And we'll have Dr. Berghella kick us off with the first paper.
Yeah, we were delighted to get this article from this group that does a lot of, twin-to-twin management, well known around the world, from Europe. Management of twin-to-twin transfusion syndrome, which continues to be a big issue in MFM, obviously. On top, you'll see from their visual abstract, some of the continuing important papers being published, kind of putting together the latest updates, increasing better outcomes in terms of live birth rates for 1 fetus going to 89% and 2 fetuses 65%. I remember, Mo, 20 years ago, I published a paper saying that 70% of twins in twin-to-twin transfusion would die, natural history. So obviously with laser, having 2 fetuses, 65% of those pregnancies survive. It's major. They also commented on the Solomon technique being associated with less recurrent of TTS and TAPS compared to selective autocoagulation, but associated with more prom and placental abruption. And then in terms of fetoscopy, always some improvements there, but early gestational age and amniotic infusion volumes of more than 1 liter associated with higher incidence of PPROM. Obviously, fetal surgery still associated with preterm birth, which we're trying to fight, and indomethacin seems to help perioperatively versus cerclage and pessary. I think not enough data yet to say they're beneficial. Stage 1, I think, is one of the most controversial because we see it also very commonly, even in non-fetal therapy centers. And if you expectantly manage about 41% of the time, that's okay, and they do okay, but 59% they need rescue procedures. I think we need more RCT data on that. And then if there is associated FGR together with twin-to-twin transfusion syndrome, survival is increased, demise is increased, especially in the donor, and similar long-term neurodevelopment. So if you're interested in twins and twin transfusion, I think there's a very nice article that puts together these updates and much more. So we're really happy to publish such major update in AJOG MFM.
Excellent. Our next paper is pregnancy outcomes following diabetic ketoacidosis. This is a systematic review done by our colleagues in Northwestern and in Alabama. And so, for DKA, we all know, many of us have cared for patients with DKA in pregnancy, significant morbidity to the mother and potentially mortality as well. And that can be associated with adverse outcomes to the fetus. But, the data about DKA in pregnancy really stems from case series and case studies and not with more rigorous study design. And this group tried to find through the literature if there were any available data from RCTs or observational studies that could assess, the additive effect of DKA in pregnancy. And so they did a systematic review through 4 databases. They ultimately were only able to find 7 RCTs or observational studies They tried to have it look at comparator groups, so one group that would have DKA in pregnancy versus a control group. Unfortunately, only one study was able to have had a comparator group. The others were just cohort studies. Ultimately, they found in this data set that, as we know, there's increased risk of cesarean delivery with an incidence of about 50 to 64%, stillbirth rates of 7 to 31%, although in the last 40 years or so, it's gone down to less than 17%, but still quite high. NICU admissions about 40 to 65% in preterm birth as well, currently 25 to up to 83%. What this paper was showing is, we know that there's an increased incidence of adverse maternal neonatal outcomes, but the data that is giving us this information is really limited in not having a comparator group for us to understand the additive effect of DKA in pregnancy. So this is really a call to action for people who are interested in trying to create a study that will look at a comparator group and help us understand really the effect of DKA on adverse outcomes.
Great. The next one is systematic review and meta-analysis of randomized studies from our group, and Dr. Zulu did a lot of work here with Dr. Gullerson and colleagues, basically looking at the effectiveness of late preterm steroids, which I think continues to be a very, very hot topic after the ALPS trial. Now there are actually 6 randomized studies. The ALPS is a major weight, but there are also other randomized trials, even recent. And basically, when you put the data together over 5,000 deliveries, late preterm steroids are not associated with a difference in RDS, TTN, intubation, decommission, hypoglycemia, and death, which is obviously different than when you give it before 34 weeks, when we see death is improved, decommission is improved, RDS is improved. So there's a much bigger effect before 34 weeks. If you give it between 34 weeks and 36 and 6/7, steroids associated with a decrease in CPAP at 2 hours and surfactant use, which are certainly important outcomes, but it's not life and death anymore. And I think this is information that I certainly will use on a daily basis when I have somebody with 35-week PPROM or preterm labor at 34, 36 weeks, to kind of tell them, steroids are certainly an option. A and AJOG MFM certainly say we should counsel patients about this option. But, the clinical thing, it's really, a little bit less CPAP, with more than 2 hours. Otherwise, the outcomes are pretty much the same.
All right. And our final paper is antenatal dexamethasone versus betamethasone on glycemic control in mild gestational diabetes. This is an RCT. This is from our colleagues in Malaysia. A very interesting study. And so we know that antenatal steroids for fetal lung maturity have the additional side effect of causing hyperglycemia. But the difference in effect in dexamethasone versus betamethasone is unknown. And we know that outside of the US, dexamethasone is used quite often, and especially in low resource settings, dexamethasone might be cheaper. And so this group wanted to try to see if there was any effect for our patients with mild gestational diabetes or diet-controlled gestational diabetes. And so they took singleton pregnancies anywhere from 24 up to 37 and 0/7 weeks who had well-controlled diet-controlled GDM. And they randomized them to either receiving dexamethasone, a course of dexamethasone of 6 milligrams every 12 hours times 4 doses, versus betamethasone, 2 doses of that over 48 hours. And they had them in the hospital checking their finger sticks and recording the number of times they had hyperglycemia and over the course of 3 days. What they found was that dexamethasone didn't have any difference compared to betamethasone in the first day, but in day 2 and 3, there was significantly lower rates of hyperglycemia in the patients who received dexamethasone, with an overall lower mean glucose level throughout the 3 days of observation. And despite having more shots, those particular patients who were enrolled in the study had same rates of satisfaction in the dexamethasone group versus betamethasone group. So at least for the GDMA1 patients, it appears that dexamethasone caused fewer hyperglycemic episodes compared to betamethasone, as well as lower mean glucose levels in those first 72 hours, and is an option now for patients to consider if you think they're at risk of preterm delivery and need antenatal steroids.
Thanks, Mo. Again, I hope everybody liked the update. We try in 10 minutes to go over the 4 top articles, and there are many more articles in the August issue. We look forward to joining you next month for the September issue. And I thank you, Mo. It's been a wonderful year together, and hopefully, stay tuned again for next month.
Sounds good.
Bye-bye,
Thanks, everyone.